My name's Greg Fell, I'm a public health consultant in Bradford. Julie, I think, given my technical illiteracy, I'm going to leave you in charge of the mouse, if that's okay. So, I'll talk for about 10 or 15 minutes or so, probably slightly less. Hopefully you can all see the slides. The report that the slides are based on has done the rounds, I'm sure. And if you haven't seen it and want it, just make sure you drop us an email. And I shall send it to you gladly. It was a piece of work that we finished in September or so this year. Background. The background to the review, Julie's briefly introduced. There was, at the time, there was some uncertainty about the structure, the shape, the scope of the urgent care infrastructure around Yorkshire. It was an area that was moving rapidly. There were a number of national and local policy developments. And the Urgent and Emergency Care Standing Conference asked for a piece of work to be done to basically take stock. And this was my attempt to do that stock taking. As I say, it's a couple of months old now, and I have no doubt that the world has moved fundamentally on since then. But this is where we were. There were three main questions that we tried to get underneath. Question one was to compare and contrast how the approach to urgent and emergency care, which I've shortened to UEC, differs across Yorkshire and Humber, both at CCG level, but also at provider trust catchment population level, and then sub-regions, West Yorkshire, South Yorkshire, etc. Question number two was to begin to get underneath the differences in infrastructure, governance, strategy, what people felt had been the past achievements, what had been noted in terms of evaluation, and importantly, and perhaps most importantly, to get stakeholders' sense of future direction. And the report was principally intended for use by the AHSN Standing Conference on Urgent Emergency Care. Method's pretty simple. There was a fairly rapid document review of the various policy documents that NHS England and plenty of other people have published. Some interrogation of available data that was rapidly at hand rather than producing fresh pieces of analysis, because we could have gone on forever producing fresh pieces of analysis. So we're putting together a bunch of data that was fairly readily at hand. And then the most important bit was 20 or so interviews with key informants from provider and commissioner and other of various flavours from up and down Yorkshire, and they were very insightful. So the results are presented in three sections. Firstly, what the policy is telling us, and I'm not going to cover that at all today. The second bit is what the data is telling us, which is broadly split into population, capacity and bed base. And you'll note there that the capacity element, will come on to this, is mainly hospital capacity. That's where the data is. Workforce and spend, and then the third chunk of results is around what stakeholders are telling us, and that's split into a number of themes. Very briefly, out to 2030, Office of National Statistics and other people have told us the population will grow by between 5 and 9%. That will increase the need for urgent and emergency care, undoubtedly. Some areas are projected to grow more rapidly than others, and the population projections that both CCG and local authority level are in the report. They're certainly appended to the report, and you can get a sense of how the population will grow in each of the CCGs or local authorities. What we don't have is projected population growth by provider trust catchment populations, just because centrally nobody's done that analysis for us. It's probably possible to do. Importantly, the population is set to grow most rapidly in the elderly population, and probably to fall in some age bands which are working age adults. Particularly important for two reasons, because one, most hospital beds are filled with elderly people for all sorts of very obvious reasons, and secondly, if there's less working age people to look after the elderly people, particularly given the pretty stringent cuts adult social care is making, that will have implications in terms of the ability to keep people out of the hospital because there's less people caring. So that's pretty straightforward. The population stuff is pretty straightforward. We then looked at data on activity, and here we looked particularly at A&E attendance per thousand, and we did this at trust level. We used the routinely available on the NHS England website, the reports given that every trust gives every month or quarter, I can't remember which, for each trust, and essentially put a population denominator underneath that. The data here is all A&E attendances, type 1, type 2, type 3, and I admit that is full of all sorts of caveats. It's basically all attendances. It told a story that between 2010-11 and 2014-15, that in most, but not all trusts, A&E attendance per 1,000 rose, but it did. The range was from a 2.6% fall in eyeballing to 10% growth in another trust. So the growth in A&E attendance per 1,000 population in that catchment was varied, and so it's probably not true to give a gross generalisation that A&E attendance is growing rapidly in every trust because the data tells us differently. Now, the data is data, and then people argue with the data, and that's fine. We can have a discussion about that, and maybe we should. But so the first chunk of data is A&E attendance per 1,000. Next chunk of data is around hospital capacity. There's an obvious and very big overt attention given to flow through hospitals. There are three graphs in this chart which basically plot the long-term secular fall in bed base, and the first chart on the first graph on the left-hand side of the slide is the very famous King's Fund graph. This is national data. The local story isn't much different, to be fair. But between 1998 and 2013-14, 50% fall in bed base, and you can see that characterised by type. The top right-hand corner of the screen highlights the fall in bed base across Europe. This bed base per capita across Europe, and you can see that within the red oblong, that's the United Kingdom bed base, and you can see our bed base is falling, and also we've got a pretty low bed base to start with. And obviously, the bottom right-hand corner of the slide shows the Finnish consultant episodes between 1990 or so and 2013-14, which has at least doubled during that time period. So, is it any surprise that hospitals feel like pretty busy places? No, of course not. Bed base is decreasing, and Finnish consultant episodes are increasing. Flow is and was a key problem throughout that whole period. The next chart looks at local data, hospital capacity in Yorkshire and Humber, again split by trust, and this is bed base taken from the KHO3 return. I used Q1 audit consistently across a 4 or 5 year period, and you can see the data. You can see the data for each of the 15 or so trusts in the region. You may not be able to see it because the text is pretty small there. But again, the data largely tells the same story. The bed base is falling across that time period, across the whole of the trust in the region. But it's not falling uniformly across all trusts. Some trusts seem to be shrinking more rapidly than others, and one or two are growing. The one that was growing was the York and Scarborough issue, which I think was to do with trust mergers as much as anything else. Next chunk of data was workforce. There's very, very little good quality data on workforce. I've looked quite hard for it, not been able to find it. Certainly did some work around paediatric surgery in South Yorkshire where we really needed to go to town on what the surgical workforce looks like. It was a big black box. Again, this is national data. I have no reason to believe that the local data would tell me a different story. The consultant workforce is growing reasonably rapidly, or was up until 2014 growing reasonably rapidly. So between 2009 and 2014, there was a 16% rise in the consultant workforce, a 5.5% rise in the scientific, technical and therapy workforce, 3% rise in the ambulance staff workforce, 2.5% rise in nursing staff, 2.5% rise in GPs, and 17% fall in managers. That tells me two things. One, if we want care closer to home, we need to be mindful of where our workforce is rising fastest and not rising fastest, and ultimately care closer to home probably will need more GPs to deliver care closer to home. That workforce isn't rising as fast as some other elements of the workforce. And secondly, as the managers on the line will say, the 17% fall in managers may well impinge our capacity to deliver whatever it is that we decide we collectively want to deliver. So we need to be mindful of the workforce, and you need to be mindful that this is national data, and maybe the local story is different, maybe it isn't, we'll see. Last bit of data was on spending. This is pretty crude. This is taken from the programme budgeting data set, which is about the only nationally and very, very readily available data on spending. This is at commissioner level, and this is all commissioners in Yorkshire and Humber were aggregated together. So collectively, we spent £6.8 billion on healthcare, of which 1.57 or 1.6 billion is definitively urgent care. So that's 23%. I don't believe it's only 23%. And those of you that can see the big light blue slice on the left-hand side of that pie chart, which is community and integrated care, I'd hazard a fairly big chunk of that is urgent care, but we don't know because just because of the way it's coded. But we do have some data on spending. So then, themes that emerged from the workshops were five or six-fold. And I'll skirt through these pretty quickly. The first two sets of themes were around strategic issues and the transforming versus tinkering challenge. So strategic issues. Dialogue and strategic relationships were universally seen as important, but often overlooked in the need to be seen to be delivering stuff. And dialogue and strategic relationships were clearly important from the boardroom right the way through to the shop floor, and arguably it's the shop floor where the business happens. So we need to get that dialogue straight and understood. I don't think I heard there was a common language and a common understanding and the same culture across the relatively small number of people I talked to, and their reflection back to me was, no, actually there probably isn't common language and common understanding of the problem that we're trying to address. The issue around the tension between, there's a word missing there, a micro and a macro approach. Common theme that cropped up was our ever issue around short-term funding. We're really good at short-term funding. A scattergun approach to firing funding out to various places because we don't know which horse to back, quite frankly. So we scatter our short-term funding around in various ways, and that detracts attention away from larger-scale service and system change, and the short-term issue detracts us away from the time to embed the new stuff. So transforming versus tinkering. This was the issue of the macro-level stuff is seen as a major transformation, is seen as difficult, time-consuming and risky, with a very uncertain return on investment. Thus, tinkering, which I use to characterise incremental marginal changes, is often the default option, and it's more feasible, practical, and often the path of least resistance in the short term. Second chunk of issues from the stakeholders, systems versus services. So when I asked people to characterise what they think the problem was, what the problem was they were trying to resolve, almost all of those that I interviewed gave me a characterisation of the problem that best fits where they were organisationally or where they were professionally, whichever professional group they happened to be in. And that led me to think that this issue of we don't have a collective system understanding is quite important. Obviously, since this time we've got into the business of having umpteen vanguards up and down Yorkshire and umpteen pioneers, and whatever follows on from pioneers and vanguards, coordination of all of those will be difficult and probably important. Systems for populations looks to be the future model. So regardless of the service ultimately the population is serving, but the pressing challenge is system governance. If you're a trust chief exec, you're going to get hung by your board for the failure of your trust, not the failure of the system. And we haven't quite got a model of system governance, which is probably something we need to consider a very pressing challenge. Many of you told me about the downstream knock-on consequences of service changes and the ripple effects, which are difficult to predict, uncertain, and frankly we don't know what they are, but we do need to be probably quite mindful of them. The services then within the systems, very briefly, the hospital stakeholders very clearly told me that hospitals try their damnedest not to create demand. Patient need creates demand. And again, hospital stakeholders told me consistently that they can and do challenge the notion that money is wasted in hospitals and hospitals don't suck in business. And I forget who, but one of the stakeholders said, well, people end up in hospital because the lights are always on in the hospital. When all else has failed, there's always a hospital with lights on. Marginal tariff, as we know, is not fit for purpose, and tariff and payment mechanisms largely in urgent care are probably not fit for purpose, which was a fairly common theme. The economics of community care are uncertain. We all hope and think that care closer to home is cheaper and better. We don't know whether it's cheaper and better, actually, and a few stakeholders commented on that. Hospitals are fairly economic places to run healthcare because they have economies of scope and scale. So the automatic assumption that care closer to home is cheaper and better is challengeable in evidence, as some of the stakeholders challenge that notion too. The community offer around urgent care isn't quite right and probably needs attention. Telephone-based services definitely have a future, but almost certainly need rationalisation, and the simplified route in is certainly wanted by many too. Or workforce. No single solution, no single panacea. Many opportunities around skill mix and substitution, and many commented on a range of positive developments, particularly around urgent access to mental health professionals. We've seen north of Yorkshire particularly as something that has worked very, very well. Voluntary sector seen as important, but very underdeveloped. Capacity and capability and cross-fertilisation of new forms of workforce, and the extent to which workforce planning is picked up in local approaches to urgent care planning is uncertain. Probably not, I think, and that then begs the question, well, who is picking up workforce planning for urgent emergency care more broadly? So there are some challenges, but those challenges certainly aren't unresolvable. The knock-on impact of workforce changes requires some consideration. So an example, the development of an urgent care practitioner workforce. Those people, that's probably a good thing, but they're going to be taken from the paramedic workforce, which creates paramedic workforce problems. Flow, very important. Many people cited lots of examples about reablement teams, integrated discharge teams, etc., which have done some really good stuff, particularly around hospital flow. However, picking up on earlier, don't just consider flow in hospitals. Flow across the whole system is particularly important. We all like to focus on the supply side of things because that's what we can measure and see. We all under-focus on the demand side of things. And a number of people raised the spectre that adding more supply does risk more complexity and supply-induced demand. Both adding more supply might solve some problems, and it might well create some new problems, so we should tread carefully. Issue from stakeholders, optimal scale, planning and delivery, and that remains unfinished business, but are almost definitively mixed views on what the optimal scale for planning and delivery of urgent emergency care. If I speak to people at the level of Leeds or Bradford or Wakefield or Sheffield, they'll all say, well, it's best done at Leeds or Bradford, Wakefield or Sheffield. But then if I speak to people at Yorkshire level, they'll say Yorkshire and Humber is the best done. I think we need to come to some collective understanding of what is best done at what level, and that's to do with economies of scale and concentration of expertise, common and consistent standards, etc. So then the recommendations, very, very briefly. To footprint. What tasks it makes best sense to do once at what footprints. We would be well-minded to be neat about our use of evidence in evaluation, and there's much to be learned from the way in which the vanguards are developing with regard to rapid cycle evaluation and Plan Do Study Act type of cycles. Workforce, scaling up post-grad training, skill mix issues. There's a huge amount of work that needs to be done yet on data, developing a single story, and the use of statistical process control to monitor key metrics, and using simple stats in a smarter way. Flow, I'd forgotten to pick up, but there probably is stuff we can learn from other industries. Industries where demand is variable, capacity is tight, train planning, for instance, springs immediately to mind. The role of the citizen and the patient, shifting mindset and cultures is important. Systems for populations, probably the main game, system governance fits within that. And then I'm not convinced that further analysis will help. We'll get into the business of analysis, of paralysis by analysis, and I'm honestly not convinced that we need more data and more numbers. I think we need to work out what actions need to be undertaken. So there I'll stop. I'll just stop with this was a report written to the AHSN and then it's up to you as a stakeholder to the AHSN to guide the network what you want them to do next. Now I'll hand over to Andy.
Hi, so I'm Andy Snell, one of the public health registrars in the region, sort of involved in the urgent care system in Yorkshire. I've started off in Bradford for a couple of years now. I've got a sort of relevant clinical background as well, and through that work, the academic network asked us to, or asked me to look at where we're at with the evidence for the urgent and emergency care system. So a pretty broad focus for a review, an interesting one, especially in sort of the context of things at the moment, and I think that's kind of what the national agenda is asking local systems to do, so it was worth a try. I won't dwell too much on the detail here. There should be there's kind of two versions of the report. One is just an extraction of the tables of interventions which, from the reviews I looked at, I think there is evidence for, and so that's the sort of real summary stuff, the kind of reference tool, and then there's, hopefully circulated last week, a slightly larger report, but hopefully not too wordy, just putting a bit of context to things. So, as Greg suggested, and I think everyone knows, it's a hot potato. A&E is always on the sort of political agenda, and that on the left there is the Nuffield Trust cross-party document to advise on manifestos for the general election. We're a bit further on in life from there. On the right is, well, just in from the right is last month's BBC News headline about A&E waiting times still getting worse. In the middle somewhere are sort of the patients and providers and planners and everyone else who's trying to engage with the system and realising the system's a bit difficult and sometimes feeling like we're all being blamed for it's not working, but it is a complex system, and far right is sort of, I just started to list some of the professional bodies and expert bodies and advisory bodies that were involved in providing urgent emergency care, and realised that one slide wasn't big enough. So it's complex, and I think this is another way of looking at complexity. This report is kind of part of a bigger piece of work I've been trying to do on trying to get my head around the urgent care system, and one of the things that's been asked is a better understanding of whole system demand and whole system capacity, and this just shows, if you try and map it out schematically and simplify it as much as you can with sort of simple, clever tools online, you already get a quite complex system with lots of providers, but even more interactions within those, between those providers, and that doesn't even start to show health characteristics, behaviour characteristics of providers and patients and the whole thing, so it gets a lot more complicated beneath just those sort of physical structures. A little bit about what the data's saying, but Greg's done all the hard work. I just had to look at other people's hard work. The stuff on the sort of summary slide on the left there is drawn out of the Parliament research briefing on, I think that was the 2014-15 emergency and acute care stats nationally, and it kind of just said that as we're starting to realise now, A&E attendance in numbers isn't necessarily climbing horribly from respect to type 1 A&E attendance, and that showed that it was actually lower in last winter to previous 3 years, but A&E breach of the 4-hour wait had hiked up, longer waits to admit, they're kind of related, non-elective or emergency admissions were climbing, and with that, the actual bed availability in hospitals had gone down, probably with funding contractions, all sorts of things, which causes a rise in occupancy rates, and that's thought to, certainly Monitor, who then refined some of this analysis, think from secondary care point of view, that's a key element of the urgent care crisis, is occupancy is sort of tipped over into blockage point. And so outflow then gets blocked if the whole system functions not nearly as well. But that's the secondary care folks, and I think this, again, what Greg said, this is what we keep doing. We keep looking at secondary care, and that's part of some of the context I've described before. We look at GP workload, and we realise that's been rising equally or perhaps even more sharply, and therefore there's more demand on A&E, there's less availability of GP, there's less availability of GP, there's probably contraction in funding. I mean, that 8.5% is going back a few years ago, but and then you look at intermediate care, and we know that that's really stood still from the point of view of funding and progress for an awful long time. and we've got half the capacity we probably need nationally, and yet we all know in the literature it says that that's the sort of thing we need to create flow. So the rationale behind this review was kind of trying to understand what the national review was asking of the system, trying to get a bit of a grip of the plethora of evidence that had come around the national review leading up to it and since, and there's an awful lot out there, so I've kind of apologised for my quick and dirty approach to this review thereafter, acknowledging that it's a very complex system and lots of people are just trying to do their day job and get on with actually seeing patients and people, and someone needs to try and present to them something that's accessible to know what to do to improve it. And like I say, it's kind of part of a broader piece of work to improve understanding of the system. I'm not saying that's an easy job at all. So what did I do? Well, I looked at the published reports from the National Review, of which there are kind of three now. There's the original end of phase 1 report, Higher Quality Care for All. The third is one in between these two, which is an appendix to that, which is the evidence base, and that's a really good document, I think. And then more recently, the Safer, Faster, Better Care, which came out. And I looked at that, although it's got some useful interventions in there, and it's got some evidence underlying it, of course, I really looked at that to see what was being asked of the system and how it can distill down some aims from it. And then I turned, and this is the kind of apology bit to sort of perhaps a lack of academic rigour. The quick and dirty thing was to national research and health institutions, as I've termed them, and to look at sort of high review level evidence and national guidance documents to see how we might achieve some of these aims. So the 6 aims are described on the right. Reducing inherent inefficiencies, there's detail below those which you can look in the report at, but that's essentially about trying to reduce duplication in care, multiple encounters, and there's quite a stark description of that in one of the College of Medicine reviews about febrile illnesses in children, single episodes of illness, having 13 encounters with the urgent or unplanned care system, and over half of those tend to be initiated by the system rather than, worried patients or parents. So I think that's a real key concept. And then flow through the system, we all know about trying to achieve flow, and I think a lot of that is about, in the first instance, trying to align processes, because that's one of the things that seems to upset flow. Because we don't have this sort of understanding of the whole system, it doesn't align, the processes don't align, and so we have repeated bottlenecks through the system. Reducing variation in quality, a lot of that is around geography, rural versus urban, close to acute centres versus remote from. And I don't think a lot of the rhetoric has got its head around that. There's still a lot of talk about co-locating services, which is fine, but it doesn't address some of the geographical inequalities. Patient and societal groups, so still the more deprived and higher risk, but the poorest quality of access. And then there's processes of care, and actually most of the interventions were around processes of care, and that's about adequate senior assessment and some other things. I'll move on because we're getting a bit tight on time. Improving care for particular patient groups is older patients, complex patients, multiple comorbidities, mental health and vulnerable patients, and some very particular needs there that I don't think traditionally we've done very well. And then end-of-life care, which is more about the quality issue, I think, than a quantity of demand. There's examples of that of why we're addressing those in the report. Reducing avoidable use of expensive services, I think, is about turning our sort of perspective away from sort of inappropriate use of services and understanding that the system needs to make cost-effective care more naturally the point at which patients access care. But again, not an easy one. And then develop system-wide working. Well, that's the big stuff that sounds kind of a bit blue sky, very hard to achieve, but I do think there's a lot of work that can be done in that, and that's getting down to sort of fundamental structures of the system. So what's to do? Well, I better move on, because otherwise you won't be able to see the slide that I'm reading. What's to do? From this piece of work, I think we do kind of know what we want, what is needed by the system, or what is expected of the system. I think there's still very much just local responsibility to ensure that is understood in the local context and doesn't have adverse outcomes. We've seen similar attempts to improve urgent emergency care in the past have adverse outcomes, and that's sort of about, not single focuses of indicators, having suites of indicators, understanding the wider system impacts, etc. We know some of what works to achieve this, the sort of what good looks like. I quite like that term. And it doesn't answer all the problems, but I think the point is that we're not doing a lot of the system isn't managing to do what we know already looks good, and we've got a sort of catch-up job to do around that. And I think the real challenge is focus on the above two without getting distracted by what's distracted health systems for aeons, which is the sort of discord between what we need to do and what actually happens in the real world. So, you know, we've just been told that although there's lots of cuts to health, there's going to be a boost to frontline, and everyone sort of turns to A&E, and yet when you turn to the literature, it all says about shifting towards primary care and prevention. So can we spend on frontline by actually spending on primary community care and prevention, because that will help to sort out frontline. So there's such challenges. And non-recurrent funds and winter planning, whatever winter might be these days. What's not to do? I think implementing new interventions where we haven't got evidence, I think is something that we need to stop doing. Again, I'm not saying it's an easy point. There's complex layers underneath that. We mustn't ignore our local services and population, so we need to understand that to prioritise which interventions we start with. We shouldn't assume that evidence of effectiveness from reviews like this and from national recommendations means we don't need to evaluate them once we've implemented them, because again, this is about sort of revision and tailoring to local need and local structures. And similarly, we shouldn't assume that if there's no evidence at the moment, then as a system for a certain intervention, that as the system develops, because we're talking about some fundamental changes here, there might not be new interventions that are effective in the future. So it's very much as our sort of caveat at the beginning of the report is we've got to keep an eye on things. This is not sort of comprehensive, or this is not a sort of future-proof. So we need to keep an eye on all that. I think I don't need to go into this. This is a sort of summary recommendations. I'm not going to dwell on that, because if you've got the report in front of you, you can look at it, and we'd better give some time to questions. There's lots to do, and I'm interested to know, there's sort of lots to do here, and there's lots of material for effective interventions. I'm interested to know if that sort of induces anxiety, if it reassures people, or if people are just still sceptical that it's achievable. There's some background work to do to understand local context. I'm interested to know how much of that already exists or is being done. Difficult conversations around what's being done already that doesn't work, and how do we cease such activities. There are fundamental shifts that I think could make the system more systemy, and I'm interested to know what drives and powers we might be able to use to achieve that, you know, to change the architecture that's limiting things at the moment, like money flows and things. And there's lots of contradictions out there, and I think that's something we've got to acknowledge if we're going to actually do this pragmatically. You know, the NHS is constantly getting asked to promote competition, and yet we're being asked to reduce variation. We're being asked to focus on primary and prevention care, and yet we're being given money for frontline funding. We're being asked to produce a safer, faster and better system that's also cheaper. So how do local systems manage this? I think there are ways to, but I think there are challenges within that. Yeah, so there's just a few prompts, and I'm sure there's questions already coming in.
The next one's from Andrew Phillips. It says, could the 10% growth have been in York taking over Scarborough?
Yes, almost certainly. The question was about the 10% growth in York taking over Scarborough Trust at whatever year that was. I can't remember. Almost certainly, I couldn't come up with any other explanation. That was the anomaly when we did it. There were no other major anomalies in any of the other trusts, and the only anomaly was the York Scarborough issue, which obviously was a big trust change.
Okay, we've got Colin's question now. Can you see that there?
Colin asks, is the NHS going to share this data in its regional presentation? The hospitalisation rates are higher in the north than the other three regions of England. So the question, NHS England shares its regional presentations. Hospitalisation rates in the north are higher than the other three regions in England. Did this get looked at in this review? No, not in either of the work that Andy and I did. My off-the-cuff answer is that there's probably more, certainly in an age-adjusted way, if you take age out of the mix, there's more need in the north of England, because as a rule, the north of England's poorer, and deprivation comes with more need. I've not seen the data, so I can't definitively answer it, but that would be my off-the-cuff answer. We didn't look at it. It may be something that would be worth coming back to.
Yeah, interesting.
Can participants be sent presentation following the Webex? Yes, absolutely.
Data in the
Was the spending data in the pie
chart was spending.
So the question was about the spending data that was in the pie chart, which came from the programme budgeting data set, which is available for CCG level for every CCG in the country. It gives you a sense of commissioner level spend, not necessarily provider level spend. There's a bunch of uncertainties and caveats with that, which I won't go into now, but whomever asked the question, email me and I shall bore you at some considerable length about that. It is what it is, and it's an imperfect beast.
Was it Yorkshire level?
That was Yorkshire level, yes. Yeah. That was all CCGs aggregated in Yorkshire. I have it broken down by CCG, and you can have that if you want it. I didn't put it in either the slides or the report because it would have bored people.
Okay.
Prevention is going to be an issue given the denuding effect of contracting funding for public health. Yes, it's Andrew's question. Andrew, yes. Dear Secretary of State, some things I'd like to draw to your attention, I think would be the answer to that question. Yes.
I do think, related to that, like I say, there are challenges that we need to make to the big money that's coming in around for frontline NHS services, because this is supposed to be a systems approach to emergency care, and that is all, I would say, a kind of frontline concept. So if you're going to improve frontline services with lots and lots of money, then you need to do it in an evidence-based way. The evidence, I think, is pointing towards shifting focus from acute care. I'm not saying taking money away from acute care necessarily, I just mean understanding the wider impact of acute care. So that's, I know that's like this prevention.
Yeah, and I don't think that which public health specialist wouldn't say prevention is really important. Of course it is, but the return on that prevention isn't going to be immediate. We all know that. So let's be honest with ourselves about that. Just to pick up on your other point, Andy, about the shift in the focus, it's insightful to look at the intermediate care, National Intermediate Care Audit data, which we've now got 3 or 4 years worth of data. Not every geography participates in it, but many do. And spend on intermediate care is static to slightly falling. We all know that intermediate care is important, and of course we'll then get into arguments about step-up versus step-down beds and those kinds of things. But if we want to move care closer to home, we probably need to spend more on intermediate care and community care of various types and flavours. So it's tricky and multifaceted, as we all know. So Colin has asked a question. An issue is how we map the numbers of people flowing along pathways from end to end, as much of the data is discrete, appointments, attendances, etc. Have you got a view on how we can develop pathway data, or is this a false aim? No, Colin, my view is this is the single most important thing, is to get patient-level data for the whole of whatever footprint you want, so you can do just that. You can track patients across the whatever services they use, wherever they do it. And if you look at most systems elsewhere in the world that have transformed, and I use that term glibly, they've all got patient-level data. And it is the Holy Grail, it is the Nirvana, and I know there's a whole bunch of information governance and all sorts of other technical issues, but it's not a false aim. Keep on it, and there are various people who are working damned hard on it as well. So get in touch, and we'll. But if you've got bright ideas, let's hear them, because I don't know the answer. So if you do, let me know.
The system, it keeps coming back to this. Certainly the national recommendations, as I'm sure you'll all know, that we need to understand demand better through the whole system. And yeah, I agree. There's no way to do that to the level that is being asked unless you've got sort of linked data through those pathways. You can model it, but I know other people are trying, I'm trying, and it gets mind-boggling very quickly and full of sort of inaccuracy, of course. I mean, I suppose that there's already things we can do better with understanding demand. And some of these, I mean, the ideas around obviously not using average demand and understanding real fluxes and variations in demand. And the system needs to be able to planned around those fluxes rather than around average, otherwise it keeps hitting this sort of occupancy ceiling and occupancy rate ceiling and quickly grinds to a halt. So there are things that we can already do, I think, but yeah, we definitely need to move a long way forward, I think, with pathway data.
So next question was Sue Mason's point. Sheffield, you are, aren't you? Nothing new here. We need to know how to achieve these things. Yes, there are no new ideas, and there's no neat shiny answer out there, as I know you know. I have my views on how. My personal view on how is complete whole system, whole population, vertical integration of certainly healthcare, maybe health and social care, but that might be just a bridge too far. And there's much to be learned from looking in other countries, both Europe, the States, and elsewhere, about how they've achieved that. But it's a big deal. It's a properly big deal. So we can talk offline on that, and I can bore you at length on that at some point if you need to. So, in Sheffield, I wonder whether this piece of work identifies any areas of good best practice which could be shared more widely. There were embedded in what I did, certainly, there were all sorts of interesting, neat ideas that people told me about, which I didn't pick up in the 10 to 15 minute presentation, but the various of the stakeholders have done all sorts of interesting evaluations of pieces of work that they've invested in, some of which haven't worked, some of which seem to have worked spectacularly well. I guess email me and I can put you in touch with some of that and some of those people.
But I think region-wide there are examples of things that are working well. I mean, what's reassuring from the review I did was the amount of sort of familiar names that were coming out of some of the effective interventions. And yeah, of course, there's nothing new here, apologies, but how to achieve this, I mean, that's two questions. I think Greg's response absolutely is around the fundamental changes that are needed, the sort of architectural changes I term them as. But I do think there are some specifics that still aren't being done through the wide system, and I think part of it is how not to be distracted by the other things so we can actually implement things that are effective. And a wise man once told me it's often lots of the small things that make the bigger difference rather than keep seeking the sort of major reconfiguration, because they happen anyway. We reconfigure all sorts of things every 5 to 10 years and get very upset by it, but we can still chip away with small effective interventions. So I think that's part of how to do it.
So Mike Pinkerton asked, what's our view of how the system will develop given the 3-year spending review, close to flat funding for the NHS, cuts to public health, cuts to social care? Off the cuff answer, I fear we will all retract into our trenches because when times are tough, we all revert to what we feel most comfortable with, and we retract into our own trenches and our own towers. It will take a special set of leadership to enable us to not do that. I wouldn't for a minute think that the next 3 years is going to be a laugh, because it's not going to be a laugh. Demand will continue to go up. We will continue to cut public health and social care, and it will get much tougher, I fear. And that said, I think the mood music amongst political circles, remember, if you think back 3 or 4 years ago, the mood music was around competition. The mood music isn't around competition now. The mood music is around collaboration and integration. Whether or not we can achieve that remains to be seen. But that's the best answer I can give you off the cuff, Mike. So,
what has been your engagement with urgent emergency care network strategies?
I read all of them I could find when I was doing my piece of work. They were quite hard to find, the CCG and Trust colleagues. Weren't obvious on websites, weren't readily available. So I read them all. It was worth noting that they were all wildly different in terms of the approach, the focus, the structure, where they fit, the seeming importance that was given to them, and may well have changed since I looked at them as well. So yeah, I did read them all, and what I didn't do was engage with every person in every urgent emergency care network up and down Yorkshire, because it would just have been impossible, obviously. So I tried to take the common themes that were occurring into account, and it was quite helpful in terms of the way I structured the end report, actually.
I'm slightly nervous about this anyway, because I do think, system resilience groups are, 2 or 3 years old, and they're still sort of finding their feet. I know the networks are a different concept, but where they fit into things is difficult, and I think when we're talking about a complex system, and everything we've added to it has made it more complex rather than more integrated. And duplication at that level, I think there's a risk of, and I think it's got to work very closely together, especially with understanding of the system, which I think is something we still haven't got to grips with while we're adding on sort of high-level networks and collaborative working. See.
Last question was from Sue Mason. We're developing a linked data set with patient-level data from an AHS 111 or ambulance call to discharge from hospital. Brill. Bring it on. I might be interested in talking to you offline too at some point. I've just done a piece of work on evaluating the Bradford urgent care practitioner, and that your data might be really helpful in enabling us to answer some of the questions that we just couldn't answer with what data we had. So we'll perhaps talk later about that if we can. So
well, we've got a couple of minutes left, I think.
A couple of minutes.
Okay. So if I can ask everybody to take their hand icon off, and then if you have got a burning question, we can put them back on in a minute. So Mike's still got a question he wants to ask. Are you there, Mike?
Mike Doyle? Wait, no, I haven't got a question. Sorry, I just can't get my hand down.
We'll just have a quick look and see if anybody else has got their hand up. April.
How we can change the mindset of must see a doctor now, because that's the crux of increasing demand for urgent care. I think society's changed so much, there's less family support and everybody has 24/7 access to everything. So have you got any ideas how we can change that from...
Well, I mean, I think the short answer is no, because I think the system has been trying to do it for an awful long time. You know, Choose Well campaigns and such things have been wholly ineffective. A bit nervous about that sort of perspective, because I just wonder if, although I'm not saying it's not a valid sort of question, absolutely, and how do we see a doctor now, and that often becomes how do we see a secondary care doctor now, for example. I sort of think it's, I suppose it's that. It's about a service response rather than necessarily hoping to change behaviours that we've never achieved before. I'm
a little bit schizophrenic on this. I have two kind of competing things that I just can't resolve in my mind. One is that from my perspective, I will choose what I think to be best for me or my family, and I'll go to wherever I think best. And sometimes if the default is to go to place X, place Y, or place Z, then that's what I'll do. And that's a rational thing for me to do, entirely rational. I agree with you, Andy. Our campaigns on such matters have been pretty much next to useless, or maybe even worse than useless. And then the second thing is that for years, all we've done is increase access. Our focus has been on increasing access, and, well, demand has gone up and up and up. And yet demand has probably gone up a little bit higher than baseline population growth. And, demand is going to go up with population growth. Population growth, we all know that. But our mindset has been to increase access. And sometimes I think, should we restrict access? Should we make it a little bit harder? If we do so, we should do so really carefully, with fully cognizant of the potential risks and consequences in that. But I think we've got to do a good hard think about that. All that said, about my worries about increasing access and then closing access, schemes such as pharmacy minor ailment schemes universally evaluate well and are much cheaper than certainly GP services. So we might be minded to think about some pharmacy first, minor ailmenty types of schemes as well, to enable a different form of a different way of meeting the demand that otherwise would end up in a more expensive, more intense setting.
Right. So we'll wrap up there. So thank you, Greg and Andy, for your very interesting reviews and answering all those questions. Brilliant. Just to say, we do have another Webex. We're going to try this again, even though we've failed miserably and not even got our camera working on this one. Hopefully the next one will be a bit more slick and ready to go. So we've got one on the 28th of January, and that will be Professor Mohammed and Dr. Richard Pope presenting some data analysis around mortality and length of stay. So hopefully you can join us for that. We will send out an invite to everybody. And hopefully you can join us. And thank you all for participating and enduring this full hour. We have got a post-event survey that we should be pinging out to as soon as we finish. We would really value your feedback, because we do need to get better at this and make it slicker. So please give us your honest feedback. That would be much appreciated. And just to say, we are also recording all this, and we will be putting a link on our website so you can do it all again if you want to, and slides will be available too. Thank you.